Charlene Butler is past president of the American Academy for Cerebral Palsy and Developmental Medicine in 1995 and has held numerous leadership positions within the Academy, including Chair of International Affairs, Chair of Treatment Outcomes, and a member of the Publications Committee. Early on, Dr. Butler led the Academy's effort to develop systematic reviews of interventions for childhood disabilities. Dr. Butler is unique in many, many ways. However, most notably, she was the first non-physician to be president of the Academy. As a special educator in the Seattle Public Schools, her primary interest was how to promote the overall development and achievement of independence of children with complex developmental disorders. As a researcher, her work focused on early powered mobility as a means to bypass physical impairment and foster functional activity and participation. Internationally, Dr. Butler spent nearly a year traveling around the world in 1991 and 1992 in developing countries, networking with doctors and therapists to identify notable people that should be considered for grants to help with their particular efforts on behalf of children with disabilities. Currently, Dr. Butler is retired and lives off-grid in northwest Costa Rica, yet remains active as a peer reviewer and consultant to developmental medicine on issues of systematic review methodology. Thank you so much, Dr. Butler, for being part of this tribute to past presidents and trailblazers. I'm thrilled that you're able to join us today.
It is my pleasure.
You came to the Academy in 1982 from a very different background than the other members. Most of them were exclusively healthcare professionals. You were a special educator. How did this background impact your career trajectory and ultimately your presidency of the Academy?
Well, Jennifer, another way you might have asked me about this is, what was a school teacher even doing in a medical academy dedicated to the scientific education of health professionals and researchers? The fact is that my background is a series of happenstances that pushed me in the direction of the academy. When my neighbor and best little friend in elementary school got polio and was in an iron lung, there were no school services for her. So I became her teacher and companion, and as a result, grew up wanting to be a nurse or a teacher. Teacher won out, and I got a degree in elementary education. But my last semester, I took a course called Introduction to Special Education, taught by a Dr. Wolf, who was such a dynamic professor that I went back for more after teaching for 3 years. One of the most important happenstances of all was that Dr. Wolf's specialty area was cerebral palsy and other neuromuscular disabilities. So that ended up being the specialty I chose to study. His master's degree program was highly interdisciplinary and intensive. It was located in a cerebral palsy center, which had a school component where we cycled through and observed what happened in PT, OT, speech therapy, in the classroom every day for 2 months. We learned all there was to know about CP and its management through lectures by Dr. Wolf and other doctors he invited to come and speak with us. And it wasn't until many years later that I realized that this program Dr. Wolf had created was directly influenced by his having been one of the earliest members of the American Academy for Cerebral Palsy, and probably the only educator until I came along 20 years later.
Wow.
Well, then I lucked into a similar special education situation when I moved to Seattle, where there was a model program in the Seattle schools that featured interdisciplinary collaboration with the therapists, the teachers, the nurse, and consulting doctors from the Children's Hospital. I taught there for 20 years. And another unusual happenstance pushing me toward the medical milieu was that early on there in that school, one of our therapists who had studied NDT in London with the Bobaths had organized a Seattle NDT course that Dr. and Mrs. Bobath were going to come to teach. Though it was highly unusual, I was allowed to join that course for therapists and became NDT certified. And 2 years later, we were able to all do an advanced course with the Bobaths. Happenstance number 6 pushed me still further into the medical world because when I took leave to do my doctorate in special education, one of our consulting doctors at school offered me a job in the birth defects clinic at Children's Hospital, where I first met and worked with Jeff McLaughlin. And finally, my dissertation research project straddled child development and rehabilitation. So there were doctors as well as special education professors on my doctoral committee.
Aren't we fortunate that all these happenstances happened and we had you here and we got to have you as part of the Academy because of all of this? Amazing. What a neat story. Well, Dr. Butler, you've told me that the special education programs for children with cerebral palsy and other neuromuscular impairments were strongly medical and therapeutic, and that the primary focus was normalizing motor development and behavior. How did this influence your teaching approach, and how did your thinking about it change over time?
Well, I completely and enthusiastically bought in initially, because there was universal agreement among all these experts that fixing the motor impairment would promote normal motor development, and that in turn was expected to automatically translate into more functional activity and greater participation in life roles, including school. Independent walking was the goal, but walking aids were acceptable if necessary. Wheelchairs, on the other hand, were the last option. And this last resort was offered only after kids failed years of therapy and other medical treatments. And up until that time, we accepted any means of walking, regardless of the time and effort it required. Not accepted, expected, insisted on. The NDT therapeutic approach had become dominant, and it held that early and intensive therapy would promote more and quicker normal development and motor development. And it also held that trained, diligent teachers like parents could hasten this by using proper physical handling and positioning of the children throughout every day. Yeah. But what did that mean? Well, our kids' lives were totally medicalized. The physical program looked and operated like a clinic. It was located in a wing of a public school building, though. There was a full complement of therapies, a nurse, consultants from our Children's Hospital. And our therapy occurred throughout the school day. Our kids went to therapy instead of participating in art, PE, and music classes, sometimes even missed basic instruction, classroom instruction, because they got a lot of therapy. Recess was not a time to play or interact with friends. Instead, our kids used their recess time up walking to and from the playground. And kids were frequently out of school for surgical treatments. They were big at that time. And we almost always had one or more kids immobilized on gurneys back at school post-surgery. So I was enthusiastic, but it bothered me.
I'd like to interject. It doesn't sound like school was much fun for these kids at all.
No, it wasn't. It wasn't. And you know, I guess I was influenced by my experience with my little friend back when I was 8 or 9 years old, who was stuck in an iron lung. Yeah. What most came across to me about what problem that presented to her and her friends was that she couldn't do anything with us. She couldn't go to the kiddie show on Saturday morning. She couldn't go outside, and she couldn't even just be outside and watch us play.
Right.
So yeah, it bothered me. But as long as I thought the outcome of this approach was going to deliver normal or near normal mobility, and relatively soon, I continued to be enthusiastic. But as the years passed, I realized that the motor behavior of our nearly 100 students did not change significantly. More and earlier therapy by more highly trained therapists, reinforced by parents and teachers, wasn't demonstrating notable difference. Their lives were not about doing stuff, but about medical treatment.
Right, right.
And then Marty happened. Well, what was that about? Marty was an 8-year-old child in my classroom whom I had had most of the school year. Our school program was for kids who were educable, cognitively educable. And if they were not, there was another program in another place for kids who were called trainable at that time. It had to do with the intellectual capacity. And Marty, I was on the cusp of doing the paperwork to move Marty out of our class because he was it wasn't that it was because he was a severely involved kid. He was, but not that. I mean, I had other more severely involved kids, but it was that he was passive, unbelievably passive. He couldn't sit up by himself. His extensor spasticity was so strong, he would just slip out of any chair. So he ended up laying on the floor most of the time. And we did a lot of stuff on the floor, but nevertheless, that's where he was all the time. And he didn't say hardly anything. He didn't ask anything. He didn't smile. He didn't play. He was unbelievably passive. So I'm in the process of doing this paperwork, and I'm concerned because he's laying on the floor all the time, looking up at the bottom of the tables and stuff. So one day, this adapted tricycle appeared outside my class. That meant it was a tricycle with some special handlebars and straps on the pedals so your feet would stay there. Now, we had those in our building, but I don't know what that one was doing outside of my classroom door. They were usually outside the classroom, outside the door of the PT department. But there it was, and I looked at it, and with my NDT training, I said, you know what? If I sit him on here and strap his feet down, I'm going to break up the flexion pattern, and he might be able to use this to sit, and then, be more a part of us, and see more than the bottom side of the tables and the ceiling. And so I put him on there, and unlike most kids who could still never move very well in that situation, they couldn't move the pedals. That was a big therapy exercise for him. He started pedaling that tricycle around my classroom. And before the day was out, he had ridden it outside to recess. He had gone down the hall to the office to take a message for me. He had and gone with another little kid on his tricycle who could ride a pocket trike. He had gotten the coat for one of his friends off the coat rack hook when it was time to go. Well, I was just stunned. Next day, he came back, put him on, same thing again. So I had no way to understand what was going on. Another fortunate happenstance is that it happened that the new child psychiatrist that was a consultant to our building was there that day, and I grabbed him when he walked down the hall to help me, ask him if he could help me understand this. And interestingly, and what I told him was, I've got this kid, he's totally blah, non-interactive. I put him on this tricycle. He blossoms almost immediately into a different whole personality. Then I take him off the tricycle, and I put him, I sit him in a chair, and he goes back to the other way. Then I put him back on the tricycle, and he changes immediately. What the heck is happening? Well, it was a mystery to me, but he told me that in psychiatry, it was common knowledge that youngsters, for whatever reason, who were unable to locomote independently from about age 1, demonstrated abnormal development. And in fact, in that world of psychiatry, in emotional development and problems, independent locomotion was in fact considered to be the key modality that promotes overall child development. But, I've tried to put other kids on there. Nobody else could ride a tricycle, that we were, it was just a fascinating event in my life. But out of that experience was born the first compelling question of my professional career, which turned out to be a developmental medicine question. Can children about 1 year old with severe delayed or restricted locomotion use a substitute form of independent locomotion that's so functional that it does not hamper their movement and interaction with people and objects? Could it actually bypass motor disability and promote cognitive, language, social, and emotional development?
This question eventually led you to your doctoral dissertation research on powered mobility for very young children. Can you tell us about that work?
Yeah, well, it had a rocky start, I can tell you. When I was organizing the study to do it, recruitment of any study participants looked like it was done, not going to happen, because the head of the spinal muscular atrophy clinic at that time at Children's Hospital sent a letter out to all of their parents that they should decline if invited to participate in this particular piece of research, which was exploring whether kids about that young, about 1 year of age, could even use powered mobility. And this is what she wrote in her letter, which I memorized and I kept all these years. If children have an easy means of locomoting, they will no longer struggle to learn to walk. Therefore, you must not let your kid do this.
Unbelievable.
My thinking and proposed research flew in the face of established medical dogma. It was heresy.
Yeah.
Fortunately, there were other doctors with equal standing, the head of the orthopedics clinic, the head of the rehab clinic, and the birth defects clinic, who not only continued to encourage me, but helped me get the minimum number of study participants that it was required for me to actually conduct that research. Wow. So this was the work. You asked about that work. Well, that was the work, but almost equally important was dissemination of the work, which was going to be another hurdle. I had realized that my target audience was doctors and therapists, usually hospital ones, because they saw these kids and their families early on in life. Mm-hmm. But I didn't know how to reach them. Then the academy came into my life. As another happenstance, when I completed my doctorate, Lynn Staley, the head of orthopedics and the editor of Journal of Pediatric Orthopedics, invited me, and together with Jeff McLaughlin, sponsored me to join this medical academy called AACPDM. And I realized these members were the earliest people who counseled families about what was in their child's best interest. And they were the doorkeepers to what their children even were offered as treatment. Moreover, developmental medicine and child neurology, which was the most relevant journal in which my work could be published, was the official journal of this academy. So my initial dissemination of information attempt, that is publication of my first paper, got peer reviewed by the editor himself, Martin Bax, who himself was a developmental pediatrician. And he sent me an encouraging note. And then finally, the dissemination of this information through my first professional presentation, which was going to be now as a member of this new academy. This academy I just joined. So there was a further glitch there about the dissemination of information at that level because the paper had been accepted by the scientific program committee, but it was not in a venue where I could show the video of the kids using power mobility, which was critical to the whole presentation. Right. Jeff McLaughlin, I discussed it with Jeff McLaughlin. I said, it's not even worth me doing it if I can't, do it and show the video. So he said, well, you should call the scientific program chairman. His name is Peter Rosenbaum. And I did, kind of fully expecting to be blown off. On the other hand, what happened was that he not only understood, he told me that, yes, he would change that venue and that he would be in the front row to hear and see my presentation. Given the experience I had had with that doctor in Seattle who had blocked recruitment of kids for my study, Peter's help in telling me that he planned to be in the front row to see my presentation was especially meaningful, because I really expected someone in this medical audience might metaphorically attack me for my heresy. And finally, the final thing I want to say about my powered mobility work is that it being selected as one of the 12 most important papers in the first 20 years of developmental medicine and child neurology publication was an extraordinary validation of the work, but it was further and a distinct honor that Peter Rosenbaum had written the commentary.
Truly an honor. Ultimately, you became president of the Academy, and the topic of your 1995 meeting became evidence-based medicine. Can you tell us about how that evolved?
Well, that grew out of the second compelling question that had been bubbling up in my professional life. It arose first when I was a teacher, and again after I began attending annual meetings of the Academy. Here's what drove the question, which was, what do we really know about the outcomes of the treatments our kids are getting, and how trustworthy is what we know? So as a teacher, it came to me because of the multidisciplinary nature of cerebral palsy management results in multiple types of treatment recommendations. Orthopedists recommended orthopedic treatments, neurologists recommended neurological treatments, physical therapists recommended physical therapy treatments. Moreover, there were multiple and competing physical therapy approaches. NDT, Voita, conductive education, Dolman-Delicato, etc. Parents of my students often talk to me at school about how confused and even distraught they were at being caught up in all the different recommendations coming at them. Yeah. And even in overt disagreements between their healthcare professionals. Subsequently, as an Academy member, the question was driven by the fact that I was disappointed that the Academy annual meeting programs did not address this problem that troubles us all back home. It was essentially a show and tell meeting presented by various experts, sounding quite authoritative, yet basically presenting anecdotal outcomes, or at best outcomes of their case series studies. I longed to go to a meeting where the walls of the main lecture hall were lined with flip charts, one for each of these interventions, and the flip chart would summarize what outcomes we knew about each one and how trustworthy they were, and we could compare them. Once elected president, I realized it might be possible to pursue that question by making it the theme of my annual meeting. Moreover, it had become timely and possible because of several winds of change, most notably that medicine in general was on the cusp of a paradigm shift to evidence-based medicine.
Exactly.
Now, I need to interject here that there was another reason that we were a show and tell society. In the 1960s, the Academy was sued by Dolman-Delicato by having publicly expressed a position that did not support their treatment approach. 20 years later, when Al Healy was president, he proposed to the board that the Academy begin publishing white papers to take a position on treatments, but it was voted down, citing the earlier legal problem. But by the time I was nominated, Peter Rosenbaum had been advocating for and educating Academy members in annual meeting presentations about research methods and trustworthy evidence, after having spent a year himself studying with David Sackett, father of evidence-based medicine, and Gordon Guyatt, later father of GRADE. Also, Murray Goldstein, head of the CP Research Foundation was active in the Academy at this time, and he offered to financially support kind of a pre-meeting to address issues and problems of doing such an annual meeting that I was proposing. So I ended up essentially being the ringmaster of people brought together from within and outside the Academy to do this. And in fact, we pulled off that meeting with all attendees voting on the last day. Shall the annual meeting of this Academy continue to be basically show and tell, or shall it present the efficacy of interventions based on trustworthy research evidence?
Aren't we fortunate that that's the way they voted? So what happened next?
Well, the board of directors initiated a committee to develop how to do this. You know, we were still concerned, you know, at the, you know, not to be making statements. We were really intending to just do evidence reports, you know, that would pull all this stuff together. You know, the flip charts around the walls of the meeting hall that I had visualized earlier, you know. This new committee, the Treatment Outcomes Committee, based its systematic review process, which what it turns out it was a systematic review process, on the Cochrane methodology that was being developed for evidence-based medicine, but with necessary modifications that because we had some constraints from our developmental research situation. And these modifications turned out to actually make two major contributions to evidence-based medicine in those early years. One, it introduced what eventually was known as the ICF, or the International Classification of Functioning Disability and Health, which has subsequently been commonly used now, more so, in developmental medicine and rehab papers. And second, it adopted Sackett's levels of evidence to be able to include studies other than randomized controlled trials, to which the Cochrane systematic review method was limited.
Fascinating. So you've mentioned to us some of the Academy members who became your trusted colleagues and your friends. And can you tell us about some of the key figures, other key figures in your Academy experience?
Well, I've been blessed with too many to name people who have welcomed me as a member. Peter Rosenbaum and Al Shearzer have been main threads that run through the tapestry of my 40 years experience in the Academy. Peter has been a vocal and continuous supporter of powered mobility, as well as viewing treatment through the lens of child development and participation in life roles. He has been my spirit guide in all things evidence-based medicine. And Al was an immediate kindred spirit, having been an educator himself before he was a doctor. Al gave me the opportunity to help him realize his goal to make the Academy international through development of an international affairs committee. And that directly resulted in the most life-changing year of my life, when I was able to network with our colleagues in cerebral palsy programs around the world. This was primarily possible because of the 120 letters of introduction I had from Academy members that caused me to be warmly received everywhere. Editors of Developmental Medicine Child Neurology, Martin Bax and more recently Bernard Dan, took me under their wing and have given me years of opportunities to work with them to address issues of conduct and quality of systematic reviews. And finally, Jim Gage. Jim was chairman of the nominating committee that broke ranks with tradition and nominated not one, but two women in a row for president, one of whom, me, was not a medical doctor. This led to another non-medical doctor nominee a few years later, and since then, 4 physical therapists, all women.
So what advice do you have for the Academy?
I'm really glad to be asked this because, you know, I've been actively involved with the Academy one way or another in evidence-based medicine issues and activities since 1965. And the main mission of our Academy is scientific education of healthcare professionals and researchers. But we're faltering now, not in the past, but now we're faltering in that mission related to providing education about what constitutes robust scientific evidence as understood today. Specifically, I'm urging the Academy to respond to the warning that was personally delivered to us by one of the world's foremost experts on the credibility of medical research, John Ioannidis, who was the keynote speaker at our 2014 meeting. He personally warned us that, and I summarize that message, repeated empirical research has demonstrated since 2005 that as much as 90% of published evidence in medicine is, quote, misleading, exaggerated, or wrong. His warning included the equally important but positive message that research methodologists and the EBM community at large had already responded through international consortiums and to identify solutions and develop tools to improve the conduct. These procedures and tools are made available worldwide. But the dissemination of this warning of the methodologists and the solutions that have been developed has been slow to reach the clinical world, where few of us, follow a methodology literature. Clinicians need our medical societies to monitor that literature and keep us up to date on its continuous evolution, especially on such a major issue as the reliability of our research evidence. And now, 6 years later, we have a more direct warning about the state of developmental medicine research. Medical specialties began using a widely endorsed 2017 AmStar tool that makes it possible to critically appraise systematic reviews of intervention. All of these studies so far have demonstrated high rates of flawed systematic reviews, as Ioannidis had reported, and low confidence ratings. Well, what about us? What about developmental medicine? In June of this year, 2021, Developmental Medicine and Child Neurology published such a study. Its title is Quality Appraisal of Systematic Reviews of Interventions for Children with Cerebral Palsy Reveal Critically Low Confidence. Specifically, what that means is that 88% of the 83 systematic reviews published worldwide in the last 5 years are not just low quality, but critically low because of multiple and varied deficiencies. And therefore, they cannot be considered reliable. So I'm using this opportunity today to urge the leadership, our Academy leadership at this moment, to make an all-out, visible to all effort to alert our members about the flawed nature of our systematic review evidence and what must and can be done about it by all of us. I want our members to know that developmental medicine is beginning to take measures to raise its standards to assure that it's not publishing untrustworthy systematic reviews. Our Academy needs to be training us, its members, about how to meet those standards. It's my belief that for our Academy to continue as a global leader, transparent and trustworthy systematic reviews and clinical guidelines published under the imprimatur of our Academy must be our absolute priority. This is what we, our patients, and families depend on and deserve.
Dr. Butler, is there anything else you'd like to add?
Yes, actually there is. I do want to say that as a member of this very unusual Academy, I've been privileged to know many of the trailblazers in our field, and even been given the opportunity to do a little trailblazing myself. But even more important, I want to say that I have been embraced into a village-like culture in which working and learning together has made meaningful contributions to what we all care about and has forged friendships in the process. I've been very lucky.
Absolutely. Thank you so much. This has been an amazing interview, and I've learned so much from you along the way. And I'm grateful that the Academy embraced you and brought you along into their village. Thank you, Dr. Butler.